Or is that for you? Okay, thank you very much. So rather than talk about boring things like J-pouches and mucosectomies or ostomies, I'm just going to talk about basic colorectal stuff and cancer. March was Colorectal Cancer Awareness Month, and it's amazing to me how, for as common as the disease is, how little is really known and taken care of throughout the medical community. So I'll just start with a quick case. You got a 54-year-old female who never had a colonoscopy, who recently went on a trip, got constipated, had some blood per rectum and some pain. She comes in to see you as a colorectal surgeon or a general surgeon for evaluation. So you see she's got some external hemorrhoids, a little fissure and a skin tag here, and what's the treatment? So the basic things that we talk about is doing warm tub baths, sitz baths, a bowel management program to help her constipation, and what else does this patient need? Colonoscopy, there we go, okay. And the reasons for it for this patient is she's 50. I sort of gave a hint that said that she's never had a colonoscopy before, the change in the bowel movements in the blood. Okay, so who can get colon cancer? Just about everybody can get colon cancer, and all of us know the famous people out in the community who sort of turned their experience into public service announcements for screening and treatment. So the statistics, 5% lifetime risk of getting colon cancer. It's currently the third most common cancer for men and women, and combined it's the second most common cause of cancer death. Each year in the United States, there's about 150,000 new cases, where about 100,000 are colon, and deaths are about 50,000 a year, where about 40 to 50,000 of them are colon. Etiology, genetics certainly plays a role. We all know the familial hereditary conditions, because that's what the tests always ask about, but all told, it's only about 1 to 3 or maybe 5% of all colon cancers. The most common pathway is the acquired, the polyp to cancer sequence, which has been outlined numerous times, and you have sort of loss of a lot of the regulating tumor suppressors and genetic regulators that go from an adenoma to a carcinoma sequence, which we think takes about 10 years. So talking about polyps, most cancers will all arise from polyps. 30% of all patients, or all people, can develop a polyp over the course of their life. So 5% can get a cancer, but 30% will have a polyp. And about 40% of people with a polyp will have more than one. So therefore, and we'll talk about this with screening, a full colonoscopy is needed for people for adequate screening and surveillance, as well as the fact that if you have a cancer, there's a much higher likelihood that you also have a synchronous polyp. And cancer in a polyp is a special consideration that we're going to talk about in just a second. So we know the sequence from polyp to cancer, but does colonoscopy and polypectomy decrease the incidence of developing cancer? And if it does that actually lead to improved survival? And the answer is yes. And we've known this for a very long time. This is a paper from the early 90s in the New England Journal of Medicine that showed that colonoscopy and polypectomy led to almost a 90% risk reduction of the development of colon cancer. These are just people who were screened appropriately and had polypectomy. Subsequent to this and following patients out, we see that there is at least a 50% risk reduction of dying from colon cancer if you are screened and have a polypectomy. And this is shown over and over from all different populations. So the take-home message from what I've started with so far is screen, okay? But who and how? So we'll talk about this. This shows up on the ABSITE exam as well as shelf exams for the students. There's not many of you here today. So if you divide into the risk groups for screening, your average risk group are people who are asymptomatic with no risk factors. So you don't have a family history, you don't have IBD, things like that. Okay, and that's the most common group. Your moderate risk group, patients who have a first-degree relative with colon cancer, a personal history of polyps or a personal history of a colon cancer yourself, and things like Crohn's colitis. Okay, these are, even though that this is the current recommendations, I think that here at Sinai and as well in the colorectal community, we actually feel that Crohn's colitis and ulcerative colitis actually have the same risk for development of colon cancer, even though it's stratified differently here. And then the high-risk groups are going to be the people who have the hereditary syndromes. All right, so the average patient, we recommend that you start screening at the age of 50. You have a lot of options of how to screen, but the take-home here is get a colonoscopy. Nothing else is as good. And if you find anything on these neat virtual colonoscopies, you still need a colonoscopy afterwards, and all of these require a bowel prep, so you might as well just get a colonoscopy because you get the drugs to have a nice sleep anyway. If you're an increased risk, you sort of individualize. For FAP, though, you start doing flex SIGs early in puberty, and once you hit hundreds of polyps, you just recommend a colectomy. You usually don't go past the early teenage years. And for HNPCC, if you knew about it from beforehand, you start at the age of 25, and then you go usually 3 years after that, every 3 years. So screening colonoscopy rates, we've known for a very long time that this saves lives, but with our goal of trying to get 90% of the population who needs to be screened to get screened, even in New York, we're only at 57%. Okay. A little bit about the staging, and this has changed about 1.5 years ago, mostly for the T4. But again, T0, that's your tumor in situ. T1, limited to the submucosa. T2, into the muscle. T3 goes through the muscle and into the serosa of the bowel. And then T4 is if it involves, a T4A involves the visceral peritoneum of the bowel, and a T4B is if it invades a adjacent structure. Nodes, really it's only important to know if you have them or not, all right? And Mets, it's either you have them or not. And staging is very easy. Stage 1 is a T1, T2, N0. A stage 2 is a T3, T4, N0. Stage 3 is any T with a node. N4 obviously is any T, any M with a Met. And the reason it's important to know your staging is because your survival is predicated upon this. So for early stage disease, there's a very high survival, okay? For stage 2 disease, I would argue that the number is actually higher than this, but this is overall survival. This isn't just colon cancer survival, so the number's a little bit skewed. Stage 3, there's a huge drop-off in your survival, but with adjuvant therapy, patients are living longer and longer with a higher risk of cure. And stage 4, for all comers, it's still 5% 5-year survival, although you will have isolated patients who have resectable Mets, and we'll talk about that later. So the workup, currently for colon cancer, the things that you see here are indicated for the workup for pre-op staging. And very importantly, I feel that the tumor board, to have your gastroenterologist, your radiation oncologist, your oncologist all available with the surgeons to talk, to come up with a treatment plan is very important for all patients with a new diagnosed colon cancer. Primary treatment for colon cancer, surgery, okay, which is great because we like to operate. Nothing is as good as surgery for colon cancer, all right? Yes, you can do adjuvant therapy. Currently for colon cancer, which is what we're talking about, it's really only indicated for stage 3, stage 4 disease. It's for stage 2. It's still considered for certain patients with stage 2 disease and some adverse histological findings, but it has never been shown to improve survival, disease-free or overall. Radiation is pretty rare for colon cancer, and it's basically because there are a few areas within the abdomen that you can radiate safely without interfering with adjacent structures. But it's, intraoperative radiation is used at certain centers, and for palliation, radiation can be used as well. So surgery, the surgical axioms, high lymphovascular ligation. Depending on where the tumor is, you're going to take that feeding vessel as close to the root of the aorta as you can so that you can get all the arterial venous blood supply as well as the draining lymph nodes that follow along there. A couple of years ago, it was really advocated that you needed to get at least 12 lymph nodes, and this was a measure of how good of a cancer surgeon you are, is if you could get 12 lymph nodes. It turns out that that's more has to do with how good your pathologist is and how much time they want to spend looking at the specimen. But we do know that you want to get at least 12 to accurately stage the patient in terms of positive and negative nodes. And then Enbloc resection, colon cancer is one of the few that if you have T4 disease involving an invading structure, if you can safely get it out with removing the contiguous structure, you should do so. So overall, the results of surgery for colon cancer are pretty good. You know, I put this picture because it was really dramatic. This was a case that I did last year in this gigantic tumor, which I was really pleased that I did this as a Sills laparoscopic colon resection, but then I had to make a 12-centimeter incision just to get the thing out, and I realized in retrospect I should have just done it open. But this really impressive tumor was really, it was just a T2N0. And so this guy was effectively cured from his operation. Mortality is quite low, and it's really dependent on what the functional status of the patient is. If you can tolerate an operation, it doesn't matter what advanced disease that you have. The surgeries are pretty safe. And the overall survival for all comers is pretty good. This is 5-year data. Okay. Local recurrence can be as low as 3 to 12% for colorectal cancer for all comers. So special considerations: cancer in a polyp. Do all of these need surgery? This is after an endoscopic biopsy or just a visualization and then a referral to a surgeon. Is laparoscopic resection safe to do for colon surgery? And what do we do for the patients who present with advanced disease, either local extension or metastatic? So here's a case that I did from my fellowship year of a cancer in a polyp. This was an adenocarcinoma. We did a sigmoid resection, and you see this really long stalk that it's on. And in retrospect, this turned out to be a T1 tumor, and 0, this could easily have been treated, if not cured, just with a polypectomy. Okay, and here's just showing, you see this polyp, but it's really on a long stalk, and it just shows how you can remove it, and if you have a good base for a T1 lesion, you can be cured. And by definition, all of these pedunculated polyps are going to be T1 because they're not invading into the muscle. It's all submucosa that's stretched out. All right, so a little bit on the Haggett's classification for cancer in the polyp. You can sort of read along, but for almost all of these, you can observe them, all right? And the big consideration for surgery here is what is their risk of being able to clear the polyp to get a negative resection, and what is the risk of having concomitant positive lymph nodes? Because for a T1 lesion, up to about 5% of these would have concomitant positive lymph nodes that you wouldn't know about if you just did a polypectomy. But the risk goes up for level 4, so for all of these end or villus polyps that could not be completely removed, we recommend formal surgical resection. Some of the other things to consider for polyps, especially if you don't have a clean base, which is defined as at least 1 millimeter, is whether or not the histology or pathology of the polyp has any of these negative prognostic findings, because these also correlate with an increased incidence of concomitant lymph node mets. And so you might consider to do a formal surgical resection in these patients as well. Laparoscopy, I'm going to go through this a little bit quicker. When laparoscopy first started being used in the early 90s for colon cancer, there was actually a high incidence of getting cancer recurrence at port sites. And there was also a question of whether or not your cancer resection would be adequate stage for stage. This has been studied over and over again. We can talk about the pros and cons. This is old data. But this trial that came out, this was the COST trial. This was published in 2007. This sort of put it to rest that for colon cancer, laparoscopy is safe to do for colon cancer in terms of oncologic resection and outcomes. What about the patients with advanced disease? At least 20% of patients are going to present either with metastatic or locally advanced disease. This can be for patients who present with hemorrhage, obstruction, or perforation, T4 tumors, or metastatic. Okay? The basic axiom, though, is that if you, first of all, in an emergency situation, you're going to do whatever you need to do to save the patient's life, even if you're not going to do a cancer operation. But for the non-emergent situations, all symptomatic cancers, an acceptable surgical candidate, you should resect. So this includes people who might even have liver mets, but they're obstructed or they're bleeding, requiring transfusions. It's kind of horrible to slowly die from a chronic obstruction. So we're not going to get into talk about colonic stenting or just palliative ostomies, but if you can resect safely, you should do so. T4 en bloc resections we talked about, are done, and you also want to look for the metastases, and you want to individualize your treatment plan for these patients Sometimes if you have a young, healthy person who's been worked up adequately, there's just one liver met sitting in the left lateral segment that's going to be a non-anatomic resection and quick and easy to do. You can consider doing that at the same time as a resection of your primary. For patients who might have bilobar liver disease, you might want to give that person chemotherapy for a couple of months and then re-image them. And as long as they haven't had disease progression, which a lot of these people will, you might consider doing a stage procedure where you can resect the primary and then come back later to do the metastatic disease. But the bottom line is that it's individualized, and can't stress more about a GI tumor board to help make these decisions. Colon versus rectal cancer. What's the difference? Is it the population of the patients? Is it the age that you present? Is it the type of tumor? Is it the aggressiveness of the malignancy? No, it's all the same. The only difference is the location, okay? And so important to know is that the pelvis is confined by bone. Other abdominal organs don't come down to where the rectum is. All right, this can make, from a surgical standpoint, a little bit more difficult because it's a more closed space and further away, whether this is open or laparoscopic. There's also different course of lymphatic drainage because there's 3 different vessels for rectal blood supply and lymphatic drainage, so your resection is tailored a little bit differently. You also have the opportunity for rectal cancer to preoperatively stage the patient, and that's because you can just easily either feel the tumor, put an ultrasound probe on it, or do an MRI and know that the tumor is going to be fixed rather than in the colon flopping around and not get a clear picture while you're in the MRI machine. And the reason that that's important is that your different modalities of therapy, so for chemoradiation, which is usually only used for adjuvant therapy, for colon cancer can be used as neoadjuvant therapy in rectal cancer. So this is just showing anatomically, looking down into the pelvis and the rectum. You know, you got your pelvic sidewalls, you have your iliac vessels here, your ureters crossing right over, you have the bladder and prostate in a man, the vagina anteriorly in a female, and so much more difficult for resection and for rectal cancer. Looking at the lymphatic drainage, coming off of the IMA and the superior hemorrhoidal is the proximal rectum blood supply. Coming off of your internal iliacs, you have the middle rectal blood supply, and then off of the pudendal, you'll have your inferior rectal. And this sort of gets into the concept of the mesorectum, which is that there's more of a circular fatty envelope that surrounds the rectum, particularly infraperitoneally, where all of that tissue contains lymph nodes and needs to be cleared in order for formal oncologic resection. This is just showing a pathologic specimen clearly, showing the mesorectum, showing that it's a complete circular fatty envelope surrounding the rectum, and how you can see on preoperative imaging with an MRI the perfect pictures that you can see of the mesorectum to adequately stage your patient. Staging is the most important step in the management of rectal cancer because these patients can get different modalities of treatment first, whether it's radiation and chemotherapy first or surgery first. So doing it right beforehand is very important. There's local evaluation, regional, and distant. For local, it's pretty easy. It starts with a digital rectal examination. Okay, you can feel most of these even up to 8 to 10 centimeters. You can get an idea of whether it's fixed to the rectal wall or to the bony pelvis, whether or not it slides over the mucosa, meaning it could be an early stage lesion. Okay, you want to do a rigid scope. I'm sure everybody's heard about this is better than a flexible scope to really truly figure out the distance from the anal verge, so you don't have looping of the scope and get a false number for the tumor being much higher than it really is. So a rigid scope is helpful in that. And you also want to get a colonoscopy on these patients. A lot of times what will happen is a patient will go to GI for a rectal bleeding workup. They'll start a colonoscopy. They'll find a distal lesion. They'll biopsy it and they'll abort the procedure because that's the source of their bleeding. But if you remember what I told you before, about 60% of these patients will have a synchronous polyp, and at least in some studies up to 7% will have a synchronous cancer. So you want to make sure the patient has had a formal colonoscopy. You don't do the patient any service if you treat the rectal cancer and you leave a cecal cancer behind. The regional evaluation is either endoscopic ultrasound or MRI. These are essentially equivocal in today's technology and the frequency of use in terms of adequately staging, and it's just up to the center and what they do more frequently. This is just showing endoscopic ultrasound. You put the probe right up against the lesion, and you see these layers. The analogy that's given is a double Big Mac in terms of the white and black, so you can see the different layers. And here's a picture showing a tumor right here. You can truly see how it's confined within the muscular layer. This was a T2, and here you can see a lymph node. Usually anything over 9 millimeters to 1 centimeter is considered malignant, and that corroborates over 80% with surgical pathology. MRI is also done, and you can get very beautiful pictures with this. This is showing the same thing. This is a T3 tumor here because it's going all the way through the bowel wall, and there's a pathologic lymph node there. I think that overall we're using MRI more commonly because the readability of MRI to MRI is much, two radiologists reading the same MRI will pretty much give you the same report versus a different endoscopic ultrasound tech doing that twice might give you a different report. So MRI is actually used more commonly for this. Actually, also the reimbursements for endoscopic ultrasound are very poor, so you get people who are reluctant to do it. Here's your distant evaluation workup. And the considerations for the surgical management for rectal cancer is whether or not you give preoperative therapy, whether you just do a local transanal or transanal endoscopic microsurgical resection, making sure you do a radical total mesorectal excision for the oncologic principles, how much of a distal margin do you need in order to preserve sphincter function, and what is the true circumferential margin for this as well. So for the preoperative therapy, this basically came to light from a paper 2004 in the New England Journal of Medicine where they were giving preoperative radiation plus or minus 5-FU as a radiosensitizer, followed by resection. And stage for stage, they found that there was improved outcomes in terms of local recurrence. Okay, so this has been followed out, studied overseas as well as here in the United States, and we find that there's absolutely a benefit for local recurrence and stage for stage cure. So currently the recommendations are any T3, T4, N0, so you can downstage a bulky tumor, or any patient with positive lymph nodes, or any T. And so these patients will get preoperative radiation therapy plus at least 5-FU as a radiosensitizer, but most will get Folfox as a preoperative treatment. This is also considered in patients who are not operative candidates. So you might have a rectal cancer that could be nearly obstructing or bleeding, but they certainly won't tolerate an APR or a low anterior resection. Neoadjuvant therapy and even short course radiation therapy can be very helpful for these patients to palliate their symptoms. What operation? So for local excision, whether it's transanal or TEM, just depending on how high up it is, when you do an abdominal or laparoscopic operation, the radical excision, which I'll show, this is more for the residents. And then when do you definitively tell a patient they need to have an APR? And I put sort of the absolute indicators here. If it involves the sphincter, even if it melts away with preoperative radiation therapy, your staging and your T stage was set in stone by the initial diagnosis. So you would really need to be removing a portion or all of the sphincters to cure that patient. So anything involving the sphincter, you usually want to do an APR if it penetrates the rectovaginal septum. If the patient has poor preoperative sphincter control, whether it's old obstetric trauma, prior radiation for prostate cancer, whatever have you, your outcome of your sphincter function is going to be worse after radiation therapy and with a low anterior, and so you usually just recommend an APR for that. And then also for people with difficult body habitus where it might be really difficult to get down into the low pelvis and do a coloanal anastomosis, sometimes it's just a lot easier to do an APR. So for local excision, these are guidelines, these are not hard and fast rules, but you really only want to be doing it for either large polyps or T1 tumors, okay? So it used to be thought less than 4 centimeters, less than 50% of the bowel circumference and freely mobile. Freely mobile just helps you to know that it is a T1 lesion because it's not fixed to the underlying muscle. But again, this is a guideline, not a rule. And also for histology, again, for the same thing, cancer in a polyp. For some of the patients who have poor histology, where there's an increased risk that they could have concomitant lymph nodes that are positive, even if it doesn't show up on an endoscopic ultrasound or an MRI, you might want to recommend formal oncologic resection for that patient as well. This is just showing transanal, so for something very distal, this is the dentate line, so it's only probably a centimeter or two away. You want to try to get a centimeter of normal appearing tissue, full thickness through the bowel wall into the mesorectal fat. You pin it out so that the pathologist can tell you about your margins and you'll know which ones were positive or not. This is showing a transanal excision that I did last year and just sort of showing that you can sort of bend the rules. This was adequately worked up. This was found to be just a polyp. There was actually no cancer in this polyp. And it basically, as you can see, just putting in a Lone Star retractor, this thing was coming out of her rectum. It went across the dentate line or growing down through the dentate line. We talked about doing an APR for this, which she really didn't want, and so I just did a transanal excision, and this is just showing the size of the lesion, which was, I think, 8 by 6, and it turned out to have no cancer in it, so she got away pretty lucky. Transanal endoscopic microsurgery, so the principles are exactly the same as transanal excision. It just allows you to access higher lesions, even up into the distal sigmoid. It's just showing how you're working through these scopes. There's newer technique now, the transanal minimally invasive surgery, or TAMIS, where you basically are putting in like a single incision laparoscopic port with 3 trocars and using insufflation and using your standard laparoscopy equipment to do these resections. And it's technically feasible, and it's definitely appropriate for patients who are not ready themselves for formal oncologic resection. The TME, again, this is more for the residents. This is your formal oncologic resection. This was introduced to the community by a surgeon named Heald. And what he basically did is he defined the true envelope, the mesorectal envelope, and realized that if you excise this completely, and this is before the age of neoadjuvant therapy or even adjuvant therapy for rectal or colon cancer, not only did you get better oncologic survival in terms of recurrence and survival, but also that you had less of the side effects or adverse events from rectal dissection. So bladder or sexual dysfunction for men, you're able to do increased sphincter preservation because you're clearing tumors. And so this is definitely the way that we do things now, and this is just showing a schematic. So looking at a sagittal, you're going to take the entire mesorectal envelope. If this is showing the tumor and the lymph nodes sort of posteriorly here, you're going to try to get out all of the mesorectal fat all the way down to the levator floor and circumferentially all the way around the tumor. Margins, they're considered positive if the tumor is present within 1 to 2 millimeters, okay? It's really only the distal margin that matters. And as low as 8 millimeters has been considered to be appropriate from a study from the Sloan Kettering, where you have at least 5-year follow-up, and shows that the local recurrence is, if you have at least 8 millimeters, your local recurrence is the same as somebody who has more than 8 millimeters. And the reason is you can only go so far distal before you take out the sphincters, and then you have nothing to hook up to so the patient can be continent. So if you preoperatively, you have at least 1 centimeter, and technically you feel like you can get down there and take the tumor out, you can preserve that patient's sphincter. You have to let the patient know, though, that their function is not going to be what they had from before. Coloanal anastomoses, in terms of their function, is not nearly as good as a functioning rectum. But for the individual patient, it's better than having a permanent colostomy. The controversies for rectal cancer right now, we're still ongoing in determining whether or not rectal cancer can be adequately treated with laparoscopy, similar to that for abdominal colon resections. Is it safe for laparoscopy? Should we start giving neoadjuvant therapy for even T1 tumors or T2 tumors, or for bulky tumors and downstage them, and then instead of doing formal oncologic resections, we just do a transanal excision? You downsize a T3 to a T1 and then just take it out without having to do a low anterior. What do you do with the patient where they get neoadjuvant therapy and then you come back and you evaluate them, and whether clinically for your own exam and on a scope or radiographically the tumor is completely gone? Does that patient even need to have a formal oncologic resection afterwards? So for the laparoscopy, these are some of the trials that have gone on. The one in the United States right now that is still accruing patients is this trial right here, and it is currently evaluating this. The early data shows that it absolutely is safe. Unfortunately, we keep jumping ahead with technology, so people have gotten onto the robotic kick, and the accrual rate for this trial has slowed down. What about neoadjuvant therapy for earlier stage tumors? This is based on observations that let's say you do a transanal excision for what you thought was a T1 tumor and it comes back as a T2 or a T3, or if you went deep enough into the mesorectum and you popped out a lymph node that turned out to be positive. So this is a patient who was understaged pre-transanal excision. A lot of these patients afterwards still are not ready or won't accept having a formal oncologic resection, and after a transanal excision they'll go on to have neoadjuvant therapy, or technically adjuvant therapy, and the outcomes for these patients is actually pretty good. Okay? The benefit is clearly you avoid a major operation. Increased sphincter preservation depending on how low the tumor is. Currently in the United States, though, this is not standard of care, not recommended, and it's more done on an individualized basis for the patient's wishes if they're properly informed. What about the patients who have a complete response? Now here I'm saying pathologic response because we know that after neoadjuvant therapy, stage for stage, 25% of these patients, when you look at everything under the microscope, it's gone. You just see a scar. No tumor in the wall of the colon, no tumor in any of the lymph nodes. So did that patient really need that formal resection? And overseas, there are a lot of research going on and coming up with clinical findings, whether it's magnified on a colonoscopy or a proctoscopy, findings on the mucosal surface of the wall and MRI imaging that can help you to predict that a patient has had a complete response, and then they just follow these patients with every 3-month exams and MRIs, and they're finding up to about a quarter of these patients don't have recurrence. So this is why the pre-treatment nodal status and the staging is the most important factor. Again, overseas, they're looking at this and they're accruing patients into trials where they're following them. It's very labor-intensive and expensive to follow these patients, to make sure that they keep coming in for these exams. And if anybody does have a recurrence, you have to fall back to the formal oncologic resection. And again, this is not currently recommended in the United States. How do we follow our colon and rectal cancer patients after surgery? These are for both, again, colon and rectal. So physical exam, CEA for every 3 months for 2 years, and then every 6 months out to 3 years. CEA, if it was elevated preoperatively, is the first indicator for most patients that a cancer has recurred that you might not pick up on physical exam or imaging. You want to get a routine repeat colonoscopy. Most surgeons and GI doctors will recommend within a year. If a patient had a obstructing rectal lesion that you couldn't clear the colon with the preoperative colonoscopy before your surgery, you probably want to get that formal colonoscopy sooner than a year. CAT scans, in terms of the NCCN guidelines right now, are only recommended for stage 3 patients, obviously stage 4 too, but for stage 3 patients they recommend 1 CAT scan a year for 2 years. I feel that we do a lot more than that for stage 3 and even stage 1 and stage 2 patients, and it's probably just more that doctors don't want to be the person that missed a recurrence, so that we fall back on doing the imaging, but it is not part of the guideline recommendation. For patients with rectal cancer, especially if you only had a local excision, not a formal oncologic resection, follow-up EUS or MRI has been advocated because recurrence rates even for T1 tumors are as high as 25 to 40%. And then as well, PET scan has been utilized with more and more frequency for rectal cancer, and I'm finding that they're being used more commonly for follow-up, but currently it is not part of any guideline. So my conclusions: colorectal cancer is very common, it's preventable, get a colonoscopy. It will save your life. Survival is excellent if you have an early stage colon cancer. Surgery is still the mainstay. Treatment's important the patients know about that. Nothing is really better than surgery. And the neoadjuvant therapies do continue to improve, but we're sort of stuck on FOLFOX right now, and the other adjuvant therapies, FOLFIRI, and even some of the Avastin and the proliferation inhibitors aren't really helping as much, but FOLFOX is pretty darn good. The multidisciplinary approach is mandatory. You sort of don't want to be the only person who's trying to come up with the decision-making for a patient who presents with advanced disease. You want to get your surgical oncologist or a hepatobiliary surgeon involved, a thoracic surgeon if they have isolated lung mets. You definitely want to talk to oncologists beforehand to help come up with individual treatment plans for the patients.